Good afternoon. My name is Dr. Deborah Jones-Weiss, and I'm a co-director for the Center for HIV and Research in Mental Health, the CHARM Center. I'm a co-director and the head of the Mental Health Disparities Core for the center, and I want to welcome everybody for the seminar on community-based participatory research and ethics. It's my great pleasure to introduce Dr. Erin Kobetz and Dr. Victoria Behar-Zusman. Before we start, let me put a seed in your mind. At the end of the session, I want you to click on the QR code that will come up on the screen with your phone, right? And complete a brief survey. So let's just go and dive right in. Let me just tell you a few words about our speakers today. Dr. Kobetz is the Vice Provost for Research and a tenured professor in the Departments of Medicine, Public Health Sciences, Obstetrics and Gynecology at the University of Miami. She's an Associate Director of Population Science and Cancer Disparities at Sylvester Comprehensive Cancer Center and the Chief of Population Health and Cancer Disparities at UH Health Oncology Services. Dr. Kobetz also serves as Program Director for Community Engagement and Multidisciplinary Team Science Components of the UM's Clinical Translational Science Institute, CTSI. Dr. Zusman is professor at the University of Miami School of Nursing and Health Studies. She directs the School of Nursing and Health Studies Center of Excellence for Health Disparities Research, El Centro, and is a principal investigator of the NIH-funded Center for Latino Health Research Opportunities, CLARO, in partnership with the Florida International University, which is designed to advance interventions to address HIV, substance abuse, and trauma-related mental health problems among vulnerable Latino communities. She is also the director for the CHARM's Developmental Core. Please join me in welcoming Dr. Kobetz and Dr. Behar-Zusman. We're going to start today with Dr. Kobetz, and we're going to try to make our chat today informal, and we invite you to ask questions. There's a chat feature, there's a question and answer feature. If something comes up for you during the course of the presentation, you can put in a QA or a chat and I will monitor it, and I will interrupt, or at the end of the talk for each person, I'll say we have some questions that came up. We really want to get your interaction and hear from you. So Dr. Kobetz, take it away.
Hi, everyone. Thank you so much for the opportunity to be here with you. I was remarking prior to the start of the seminar how grateful I was to be having a conversation about community-based participatory research and not COVID. We'll talk a little bit about my community-based participatory research, most of which is grounded in cancer disparities. And I am really appreciative in this moment to have the opportunity to circle back to what is the beating heart of my academic career. So I don't know how many of you are aware of what community-based participatory research is. So I'm going to start off with a definition, and then we're going to unpack it a little bit. And I'm certain as my colleague follows up on the ethical considerations, she will further problematize some of the issues that I'm bringing to your attention. So community-based participatory research is a methodology that on some level turns most traditional research epistemology on its head. Because what it does is invite active stakeholder participation throughout the entire research continuum, from the onset or conceptualization of the idea to the dissemination of findings. And the reason why community-based participatory research is so different than most other methodologies is because it really begins to blend the line that many of us uphold as critical to advancing new knowledge, which is that of objectivity. Because when you invite community members or other stakeholders into research participation, it starts to blend the objectivity where there is a co-learning which occurs that ultimately influences the focus and scope of research. I thought that it might be helpful to tell you a little bit about my own experience with community-based participatory research, for it to be an applied example by which Dr. Behar-Zusman can really think about the ethical considerations with all of you about the work and its long-term implications. So I was recruited to the University of Miami about 16 years ago now. I've aged tremendously, obviously, since being here. And one of the things that I was asked to do by the then Cancer Center Director, Dr. Jerry Goodwin, was to develop a program of cancer disparities. I'm a Miami native, but at the time knew very little about the landscape of disparities, and so wanted to figure out how to best assess what was happening locally. And in my mind, there were two ways to do this. One was to look at objective secondary data that could help me better appreciate the geographic distribution of disease between and within populations. And the other was then to go to the populations themselves and have a better appreciation of what it is that they prioritized as health concerns. So as I did this exercise, starting with the secondary data, I came to identify an area with an excess burden of cervical cancer, which in my mind is an objective marker of health disparity. The reason why it's an objective marker is because when women have equitable access to the formal healthcare system, they do not develop invasive cervical cancer. And on my mapping exercise and in this secondary analysis, I kept finding this area with what seemed to be 4 times higher rate of disease than was reported anywhere else for the Miami metropolitan area, the state of Florida, or the United States. And I initially was really suspicious about this finding, thinking that it was statistical artifact and not real. And so what I did was I, focused in on the cross streets of the maps that I developed, got in my car and drove, and very quickly realized that I was in the ethnic enclave known as Little Haiti. And the only reason that I knew that it was Little Haiti was because there was a predominance of signs in a language other than English and Spanish. And I went back to the university trying to engage some of my senior colleagues in dialogue about the possibility of doing research to understand the disparity that I uncovered. And many of them were very dismissive. And I think the reason that they were dismissive is because they knew in order to do this work effectively, it would require a significant outside of time and resources on my behalf to engage the community to help me understand what it was I was observing and what potentially I could do about it. But I came from UNC Chapel Hill. That's where I did my PhD. My training was very, very interdisciplinary. And one of the methodologies that was a consistent emphasis across all of the different disciplines from which I was drawing my training was the importance of participatory action research, particularly when thinking about trying to understand and address disparities. There was sort of a theoretical emphasis within UNC that if we wanted to nominate solutions for health equity, that those solutions needed to actually come from the lives of people the voices from people whose lives were actually characterized by the health disparity that our research was seeking to change. And so this was something that I knew intimately well and was always part of the focus of how I planned to orient myself to doing work at the university as a faculty member. So I wasn't getting a lot of traction. Most of my senior colleagues were really dismissive of this idea because they felt like if I were to initiate a participatory process in Little Haiti, that it was going to really distract me from my tenurability and some of my other professional obligations, which weren't research specific. But I was kind of naive and probably egotistical and figured that their input didn't really matter because the disparity that I identified actually did matter. Here was a group of women with an excessive rate of a preventable disease who were disenfranchised from the formal healthcare system. At the time, Little Haiti was considered a federally designated medically underserved area, which implied that there were actually a shortage of primary care providers available to provide cervical cancer screening to age-eligible women and women who otherwise wanted it based on their own perception of risk. So I was really lucky that at the time there was a clinical research nurse working at Sylvester who was of Haitian ancestry. And when I approached her to have a conversation about the data that I observed, she started to open some really critical doors to me, both within the university community and also outside of it. So in the university, she introduced me to Louis Hearns-Marcelin, who's a professor of sociology and had done significant participatory research around the HIV/AIDS epidemic. And what Hearns did for me was allow me to stand on his shoulders. He basically taught me everything I didn't know and gave me an anthropologic quick course on the history of Little Haiti and particularly its relationship with the University of Miami. So one thing I would say when you're thinking about doing community-based participatory research or participatory action research is the need to do your homework and to sort of understand the political, economic, historical, racial, and other factors at play within that target community so that when you go into conversation with community stakeholders, that you're not naive to their lived experience, and particularly how that lived experience may condition their appreciation or willingness to undertake collaborative science. So what Hearns taught me was the following. That one, there were many investigators at the university who were well-intended, but he considered to be parachute scientists. And what I mean by that is that they would receive large grants, usually from the federal government. They would parachute into a community of interest like Little Haiti, collect a ton of data related to the hypothesis or scientific aims proposed in the grant, and then publish that data, never sharing it with the community or working with the community to leverage their findings for collective benefit. And over time, when that happens over and over, communities that are disenfranchised feel further disenfranchised and marginalized by the very research itself. And so it created this dynamic where the notion of research was, why should we help? Because there's no investment or there's no payback for our investment. And I think that's actually a very important ethical concern that will be discussed later in the presentation. The other thing that Hearns talked to me a lot about was the fact that during the early days of the HIV/AIDS epidemic, that Haitian ancestry was erroneously labeled as a risk factor for transmission by the Centers for Disease Control. Now, we all know that there's nothing about Haitian ancestry that increases risk of HIV, which at the point back then I think was actually still called GRID. But this stigma is not something that the Haitian community felt at the time that I was starting my research that they had effectively lived down. And I think the bigger problem, which I couldn't appreciate without Hearns whispering in my ear, was that some of the data that was used to document the increased prevalence of HIV among the Haitian community actually came from the University of Miami. Now, the research itself wasn't bad. It was like straight up good epidemiologic data that found an increased risk of a virus among a vulnerable population group. But the way that that data was then manipulated by the media led to the legitimized discrimination of a group of people who are very much already living on the margins by virtue of being Black and non-English or Spanish speaking. And so research in Little Haiti became a bit of a dirty word. So it couldn't be something that I was ever going to do on the community or in the community. It was very clear through my conversations with Hearns and others that it was going to have to be something that was done with the community. And that emphasis on that preposition is extraordinarily important because there's a lot of people who say they do CBPR in a community. Right there, you know that that's a false dichotomy. Because if you're doing CBPR, it's with the community. And it means that you have actually engaged the community in a meaningful way that they help define, that allows you to ensure that their voices and they themselves are meaningfully integrated throughout the entire continuum of study. So with Hearns' help, I started doing this process of door knocking on community-based organizations' doors. And a question that came up earlier in my pre-seminar conversation with Dr. Jones is, how do you know that you have like the right community leaders at the table? And so something that we have always done in all of my work, starting in Little Haiti and now the work that exists in other communities outside of it, was to start with a couple of gatekeepers and to allow them to nominate other people that they thought that we should speak to. And then allow those people to nominate other people that they thought that we should speak to. So it's kind of like snowball sampling in my crudest explanation, but ultimately you get to a point of saturation. And those individuals are become, if you will, the foundation of what I would call a community advisory board that also has to include stakeholders from the university who start to have bi-directional conversation, first around trust and mutual respect and the ground rules for partnership, and then ultimately how all of those things are leveraged for collaborative research benefit. So 16 years ago, I started building the first ever campus community partnership in Little Haiti using the methods that I just described. It didn't always go as well as I would have hoped. There were many people who were extraordinarily skeptical about the idea of research and partnership in research with the University of Miami, because there hadn't been an example where partnership was operationalized in a way that made sense to the community. And I think that's a really important tenet of participatory research. Everything has to be collaborative. So if I went into the community with a pre-existing notion of what partnership is, I have to be open to the idea that my definition can and should be refined by community members who are working alongside me, because at the end of the day, this is our shared work. And it is our coming together around the principles of how that work gets conceptualized and implemented that's critically important for us to uphold the tenets of this particular methodology. The other thing I would say that is a tension, and maybe this will be talked about as an ethical concern, is when you learn about CBPR in a classroom setting, and I'm guilty of doing this because I did teach CBPR for many, many years at the School of Medicine, is that it's often thought that true CBPR occurs when a community reaches out to a scientist or a researcher or somebody who's part of the institution to pursue collaboration. And I don't know how many of you are actually engaged in community-based science or participatory action research, but in my now 20 years of doing this, there's only one exception that I can speak to where the community reached out to me to talk about where we might marry our individual expertise for collective benefit. Okay, so there's a tension because there's a definition of what CBPR is, and often what happens is that definition gets watered down by both the needs of the faculty member who might want to pursue this methodology with a specific community, and then also the community's ability and social capital to know who at an institution they should work with to pursue a topic of priority for them. And so there is always that tension there, and it's always something that I think that you should be aware of. It doesn't mean that the work itself is less valuable, but it means when you're writing about this for journals that there may be some pushback by the people who are evaluating the merit of what you're talking about on the basis that you engage the community. So just keep that in mind. So we built this campus community partnership. One of the things that I would say is that it's always been a very fluid campus community partnership, in that membership is something that changes over time. It's open to anyone who wants to participate, and there are obviously some people who are far more engaged than others. And sometimes the level of participation actually varies based on the topic of conversation and where the research is in its natural history of iteration. So what we decided as a group, and the first, 6 months of meetings, we're figuring out how we were going to work together and what the rules of engagement were going to be, and what were the criteria that the community felt were really critical conditions of collaboration that always needed to be upheld for the university and me in particular to fully demonstrate my commitment to working collaboratively and not being the so-called parachute scientist who pursued work in the community for individual benefit at the expense of community progress. So what we did is I shared the data on cervical cancer. And we talked quite a bit about whether this was a priority that the community themselves identified. And to be fair, it was one. It was in the top 10. It definitely wasn't number 1, and it definitely wasn't number 10. Now, the way that true CBPR would occur is that the nomination of the focus of study would come from the community. But oftentimes what happens is that there has to be this compromise between what the community prioritizes and what this scientist or group of scientists have expertise to actually work on. And so one of the things that I believe is a critical component of any participatory research or any research generally is the need for full candor and transparency. So when I started working in Little Haiti, I was very clear that I was hired by the university to work on cancer, and that I wanted to work with the Little Haiti community on addressing issues of cancer that was nominated by them and verified by secondary data. But that there was always going to have to be an agreement that my involvement on some level was scientifically limited to this area of emphasis. And I also promised that I was always willing to negotiate and navigate community members to other experts at the institution whose area of scientific emphasis was different than my own. And there are many times where I have done that. I will never forget when I was working in Liberty City and really trying to address this high prevalence of tobacco-associated cancers, that one of the community members spoke very plainly and said, the issue in our community, Dr. Kobetz, is really not cancer, and it's really violence. And how many people in this room have a family member who has been a victim of gun violence? And everyone raised their hand. And it became very clear to me that even though Sylvester was helping organize this community advisory board, that addressing cancer was so far down this sort of Maslow's hierarchy, because basic needs around safety weren't being met, that we couldn't really emphasize scientific opportunity around cancer. And so what I did was I connected them with Gail Ironson in the Department of Psychology, who's known for doing really excellent trauma-based research. And I think she worked with them for many, many years. And then when there was issues related to cancer, they would reach out to me and I would figure out how we would work together. And so that is part of community-based participatory research, is that there always is a negotiation. And sometimes that negotiation works out the way that you want it to as a scientist. And sometimes it means that you have to take a back seat and think about the broader institutional goal and who else at the university or within your academic community may be well suited to work with community members to advance an issue that is their priority, but not necessarily your scientific expertise. So back to my story. We created this community advisory board. We decided we were working on cervical cancer. And as luck would have it, the first ever grant on community-based participatory research was released by the National Institutes of Health.
Erin, you're on mute.
Sorry, my phone is somehow ringing on my computer and I guess it turned me on mute. So what we decided is that we were going to pursue this grant, and together we came up with the research questions. The community members would say what they wanted to study about cervical cancer. I would map that onto something that was measurable. And then together we actually would debate which methodologies were best suited to answering the question, given cultural and linguistic and other constraints within Little Haiti. We submitted this grant and it was funded on first submission. And I think the rest is kind of history for me, because if I had any doubt about the benefit of doing participatory research, it was completely dissuaded. And we now had a way to work together and a framework that really defined the nature of our collaboration. So let me tell you some things that we agreed to. One, we decided that we were going to really understand what the true rate of cervical cancer screening was in Little Haiti. Because as many of you may know, when we look at large data sets like the Behavioral Risk Factor Surveillance System, we do not really do a good job of representing the heterogeneity that exists within our Black or Hispanic populations. If you self-identify as Black or Hispanic, you're lumped in to this amorphous group, and it's very difficult to differentiate the variability that exists within those groups. So that was a question that the community felt very, very strongly about answering. And what they wanted to do was to do rapid assessment surveys to get to the answer. The other thing that they wanted to know was if women are not being screened by cervical cancer, why? And that second question ended up being, if you will, the springboard for the rest of my, or I guess for the next 15 years of my academic career. The community also felt strongly that 50% of the grant dollars needed to go to Little Haiti. They wanted a community home for the research, and they wanted a community PI who would both supervise the community home and also the associated staff who'd be hired by the home. And that has been the framework of which I've done all of my work since then. If you want to do community-based participatory research, there is an obligation to invest in the community beyond the research itself. And so all of my budgets, I actually think I taught research administration how to do budgets with subcontracts for community-based organizations, where significant portions of research dollars were going to the community to ensure successful implementation of the work. The other thing I would say about community-based participatory research, which was a very hard lesson for me to learn, particularly when my children was much younger, was that it meant that I had to show up and that I couldn't just be there to talk about research or at CAB meetings, but I had to be an actual member of the community. And I had to commit my time to things that the community valued that didn't necessarily resonate with my research interests, but were community priorities. Because the interesting thing about doing community-based participatory research is that you're sort of an insider-outsider, right? You're working with the community on a topic of shared research interest. You are a partner in ensuring the successful implementation of the work and ensuring that the community has necessary resources to act on findings. And then you're always a bit of an outsider, because by virtue of your affiliation with the university and sometimes your academic background and your commitment to research, you're never actually really part of the community itself. And that's something that I would really caution all of you who are interested in pursuing this methodology to remember, that as close as you get to a community and key community members, that when you are working with that community from the lens of science, you're actually never really an insider. So we've been doing this work together for 15 years. Obviously, it extended beyond barriers. It started to think about, well, if the barriers are going to the formal healthcare system, what do we do about it? We were the first group to ever pair community health workers with a self-sampling device for cervical cancer screening, where women could self-collect cervical endothelial cells in the privacy of their own home that then could later be tested for human papillomavirus, which I'm sure many of you know is the principal cause of cervical cancer. That work has since expanded, where community health workers who are indigenous to the community of interest and actually selected by community members are an integral part of research. Because when you're talking about community-based participatory research, it's often not enough to just have the community nominate the focus of research. It's really important for the community to be intimately connected to both the sampling, the recruitment, and the data collection. And one of the ways that our community partners allowed us to, or suggested that we do this, was community health workers. I have to tell you that when this was first shared with me, I was really skeptical, because my dissertation work involved, at the time, lay health advisors, who were tremendous women, but they were all volunteers. And really the goal of these lay health advisors, who were actually the focus of my dissertation, was to use their natural helping abilities to promote health education around cancer disparity. The idea that these women, many of whom had limited formal education, would actually be responsible for recruitment and data collection was something that blew my mind, right? Because I had spent all of these years being trained to do that, and was then being told by community members that if I tried to pursue data collection, that it would undermine the legitimacy of the work, and that I really needed to employ a community health worker model. It was really upsetting, because it meant that I was abandoning my authority and my autonomy as a scientist, but it was ultimately the right decision for two reasons. One, I don't speak very good Creole. Two, there were certain cultural nuances related to discussing something as sensitive as cervical cancer that I could never appreciate, no matter how many times community members explained them to me. And three, another goal of community-based participatory research is to enhance the existing capacity within the community so that it can be sustained beyond the focus and timing of research itself. And that's always been one of my really big goals, is that as we do community-based participatory research in Little Haiti and other communities like it throughout the Miami metropolitan area, that we work collaboratively with community stakeholders to figure out how the research itself can elevate some of their goals for the community. So as an example, we used to rent space in a community-based organization. We pay the indirect cost. The people were hired by that community-based organization. Their skills could translate to other priorities for the community-based organization. And we were also buying things like computers and printers and other supplies that could serve the interests of the entire organization and not just our work. And I think that's really important. Community-based research is as much about research as it is about social justice. And that's why if any of you have ever heard me speak before really about my research and not just about CBPR, I talk about the fact that I believe my research is a vehicle for social justice, because I believe some of the work that I've been invested in with community partners for the past 16 years is intimately connected to advancing goals of those communities that may be independent of my work. And I think this is one of the biggest challenges about community-based participatory research, is that when we measure things, we're often measuring the things that are connected to the focus of the grant and not measuring the other temporal trends that are occurring around the research. They may actually be more important for the community than the research itself. And that's something that I really sort of challenge all of you who are considering doing this kind of work to consider, to think about working with community stakeholders, to figure out what else needs to be measured, to help us document the benefit of collaboration, and to think about what things change by virtue of the marriage of our expertise in a way that leads to sort of this trickle-down benefit that changes both the institution, the individuals associated with it, and the community. Now I'm going to leave you with, I think, my more recent example of community-based participatory research that arguably has been the unexpected privilege of my career. So I'd worked in Little Haiti and medically underserved communities like it for about 10 years, really pursuing issues of cancer disparity, working collaboratively with community stakeholders, both to define the focus and scope of that disparity and also the solutions to address it. And when I think about community, it's not just the members of the community that's the focus of intervention and inquiry, but it's also members of our university community who may often approach research from a more traditional epistemology. And so I've been doing this work with all of these diverse stakeholders, and I got a phone call from a firefighter who was really concerned about what he perceived to be an excess incidence of cancer in the fire service. And he wanted my help. So right there, I should have recognized that this was true CBPR. I had a community member reaching out to me to have a conversation about how we could work together to address an issue of disparity. But I actually was a little closed-minded to start. One, I didn't consider it to be a disparity because it didn't fit my traditional definition of what disparity was. And two, I was like really busy and distracted with other commitments, both in terms of my own research, my connections to the community. At the time, Sylvester was really thinking about pursuing designation from the National Cancer Institute. And so these were the things that like were keeping me very distracted. But this firefighter was a little bit relentless. He's since become one of the most important people in my life as a colleague and a collaborator. And he kept saying, this is a disparity. We're an occupational group. Our risk of disease is not the same as other occupational groups. And if you can do this in Little Haiti, you can do this with us. And so I started doing research, like background research, to figure out if what he was perceiving had any fact or legitimacy in peer-reviewed literature. And in fact, it did. There were a number of publications that upheld that there was this increased risk of cancer in the fire service. And so I decided to hear him out. And that work became the Firefighter Cancer Initiative, which is now in its 7th year of funding. And maybe it's its 6th year of funding. But it's such beautiful CBPR because the firefighters work alongside a group of about 40 investigators, from basic scientists to health communication specialists. And when I say they work alongside, it is always this sort of dyadic interaction where the firefighters have ideas that get mapped onto research concepts, and the research findings, which are mostly driven by data collected by firefighters, ultimately go back to the fire service to think about the practical solution for how we use that data to affect change. And because this collaboration is so powerful, it has led to public policy changes in a very short amount of time. And I'm certain that it wouldn't have occurred if the participatory nature of the work was missing, right? Our success is fundamentally built on our ability to share our individual and collective expertise. I don't know about being a firefighter. Firefighters didn't know about being scientists. But when we work together, we figure out where exposures occur after an incident and how firefighters take carcinogens from the scene of a fire back to their personal home. When we identify that, we can work with firefighters to think about solutions that minimize exposure in all of those contexts that are not fire specific. And when we can implement that solution successfully, we can elevate it to the state fire marshal, who then secures funds from the state legislature to ensure that we can replicate that solution for the entire state. And that occurs through the power of partnership. I want to turn it over to questions or the ethical stuff, because I'm sure I've raised lots of issues that many of you have questions about. I could talk about CBPR all day. It has been the best journey of my career. And I actually believe that one of the reasons I became the Vice Provost for Research is because working with diverse community stakeholders is not that different than working with diverse researchers and faculty across our university who approach scholarship on different topics and even areas of shared interest from very different perspectives and epistemologies. And when you can bring people together around conversation and common purpose, we accomplish a lot more. And so I'm always grateful for the lessons that I learned in Little Haiti early on, and for the partnership of faculty like Hearns Marcelin, who were willing participants in helping guide me on my own journey and making me recognize that as much as I was prepared from all of my years of training, that the greatest lessons that I was ever gonna learn were gonna be in and with a community. And always grateful to keep learning them. Happy to answer questions, and I'm sure there's going to be lots of opportunity for dialogue and debate as we talk about the ethical considerations. I'm thinking about this, Vicki, that I think I was like one of the first IRB, when you might have been like a chair of the IRB around CBPR, and thinking about even what we needed to do institutionally for federal-wide assurance to bring these engaged community sites under our IRB umbrella. And you know, how long the two of us and others have been working to sort of make sure that there was institutional support to actually allow our investigators to work meaningfully with communities and to allow communities to work meaningfully with us. There's so much more that we can do together. And I'm happy to answer questions now or to let my very esteemed colleague talk and for us to answer them together. Up to you, Dr. Jones.
Thank you so much, Dr. Kobetz. That was a really, really fascinating talk, as always. I've heard you speak before, and every time I hear you speak, I hear something new. I just want to take a moment to put the QR code up for people to do a quick survey. So the screen will disappear. There we are. please go ahead and do this survey. So I have a question. The first question that came out for us was the one that is probably on a lot of people's minds and is not necessarily germane to your work, what you've just spoken about, but is perhaps more closely related to the work that you're doing as Vice Provost. And I want to say, if you have a question, it needs to go on the question and answer box. So that question is, when will we be able to bring people from the community back to the university in order to conduct research here on campus?
Is that why you participated? Because you wanted to ask me that question? So the answer is, I don't know. Probably sooner than later. We are trying to be very mindful of population density on our campuses, particularly now that students are returning to all of our campuses for in-person instruction, and needing to ensure that we don't sort of, I don't know what the right word is, like overfill or overreach beyond our intended population density, fill up too quickly, and increase the risk of transmission. Let us get through the opening of campuses in the next couple of weeks. You may have seen that we just sent out a notification about undergraduates involved in research. It is a stepwise process, and I promise that once we ensure that that is successful, that we will be revisiting this very next little bit. I want you to know that my research is also on hold. Like, work in communities is not something that we're encouraging right now, because it means that those of us who do it are at risk of unknown exposure, and that same risk actually exists for the community members who are interacting with us. And so I very much relate and empathize with the tension that all of you are feeling wanting to get back, but there is a need to be very sort of mindful about how and when we do it, so that we can really control the potential risk of exposure throughout our university community.
So here's another comment and a question as well. And then Dr. Behar-Zusman, I'll switch over to you so that we can ensure that the time goes okay. This comment is, one thing I think that really does get hard with CBPR is when the community wants a project that is much more complicated and big than the small puzzle piece that usually one research project is made up of. Do you have any further comments about this while we try to honor CBPR, but as you say, for example, in the domain of cancer, we want to say with research projects, they're usually small, especially first projects. How do we keep the projects at a manageable size?
So I think that's an excellent question, and thank you for asking that. So there are two things that I think are really important around CBPR. I told you the first was candor. Speaking openly and honestly. And when you're talking about participatory, it also means that you are a participant in the process, right? And so your voice and your ideas and expertise also have to be appropriately represented in whatever is ultimately decided upon as the focus and scope of work, okay? So the other thing I would say is to set expectations. That's my number two. And so when you're working with the community, there's a certain expertise that they bring to the marriage and a certain expertise that you bring to the marriage. Hopefully they're somewhat overlapping. Sometimes they're actually really diverse in sort of the scope. And so one of the things I always do is sort of set the expectations of what the work can be. It doesn't mean we can't dream big, that we can't ultimately get to a place where no woman dies of cervical cancer. It also doesn't mean that we're going to solve that on the first project that we do collaboratively. And so it means that, like, participatory work has to be based in participation by all of the stakeholders who are involved, and that everybody's voice has to have value and weight. And that part of your job as the investigator is to set realistic expectations of what can be accomplished when, and to work to manage those expectations collaboratively with community members who actually may be in pain. And patience is a virtue for people who aren't in pain, right? So it's about trying to find that happy medium between what they want and what you can successfully accomplish. Because if you promise everything and you fail, then you've undermined trust, which I believe is the cornerstone of any good relationship, including relationships with communities.
Thank you. Great answer. I just want to squeeze in one more question. I think I have a few minutes. I can do that. And the question is, how you talked about identifying decision makers in the community using sort of a quasi snowball sampling approach, that, you know, a group of people become kind of a kind of almost an advisory board. Then, you know, you made the comment that gatekeepers nominate people that you think would be appropriate to speak with. Who would you call those gatekeepers?
So, you know, the way that I mean, I think gatekeeper is often a very sort of subjective perspective, right? There's no like objective way to determine who a gatekeeper is. But in my mind, gatekeepers are people who sort of represent the community in some way and are thought to have their finger on the pulse of what's occurring in the community, and also have really extensive social networks that they can mobilize around issues of common interest. And so, you know, where we started in Little Haiti was community-based organizations that we knew were serving the needs of the broader community. We knew that these people were very visible, that they were active, that many people in the community were engaging either them or the services of their organization for individual or familial benefit. And ultimately, you get down to people who are not part of like the institutional hierarchy of the neighborhood, but are lay individuals who are really the natural helpers, whose voices are critically important to helping define the narrative of collaboration, right? And so through this snowballing process, I will tell you that we identified, you know, like we would say like, okay, well, we're going to work on cancer. Who do you think should be at the table? We would get survivors. Survivors would tell us about other people that they thought were critically important. The family member of somebody who had died and whose death was publicized within the community, and, you know, really rallied people around this issue of cancer disparity. It's not perfect, right? And you should never, ever assume that you're representing the entire voice of a community. But having those people at the table is certainly better than having no one. And if you advertise things, right? Like when I started, there was like no social media. Like you can advertise through various community channels. So you could tell people about radio, you could use print media, you could use social media, you could use Twitter. Your community members can also promote this stuff. And that was other things that we did. And so we always had it around like as this very sort of open, fluid meeting that anybody could come to based on their interest. And some people would show up and they would say like, this isn't for me, this is boring. And other people would stick around and end up being like very vocal, engaged participants of everything we were doing.
Okay, thank you. Thank you. Well, let's switch gears, or kind of like maybe not switch gears. Let's just go into a shift, put in the clutch and move in a different direction. And I'd like to introduce again Dr. Behar-Zusman, Victoria. And please, Vicki, take it away.
All right, well, thank you. It's such an honor to be, first of all, on the same panel as Dr. Kobetz, who is most definitely the person who put CBPR on the map here at UM. And just mention two other people who I consider to be my mentors in CBPR, and that is Rosa Gonzalez Guarda, who today is at Duke, and Mario de la Rosa, who's my partner in Claro at FIU, and who's constantly reminding me that I need to go back to the community. So I'll just talk about a few things, and you know, Dr. Kobetz has done such a great job of really setting me up. I'm going to talk a little bit, first of all, about trust, which, as she said, is really at the heart of the ethical issues, not just in CBPR, but also in in science in general. And then talking about some of the ethical principles that we can apply to really help guide us. And then if we have time, talking a little bit about CABs, which again, Erin did such a great job of setting me up for. I'm going to start by showing you all a video that we developed as part of the Precision Medicine Collaborative. I'm part of their dissemination core. This is a collaborative between Vanderbilt, Meharry, and the trust video that we'll show in a second is based on an article that was written by the PI of that collaborative, Consuelo Wilkins. So Andres, if you could show the video, that would be great. Is the sound on?
No, the sound is off.
Conducted unethical biomedical research and have left lasting marks on communities, effectively severing any ties of trust between the community and researchers. As a result of poor experiences with health systems, unequal access to healthcare, and experiences with discrimination, these communities are further and further away from research that can impact the health of many. However, it is often that as researchers, we place the burden of mistrust on the community. But what if the burden was not placed on the community to trust, but on us to be trustworthy? Being trustworthy extends far beyond meeting the ethical guidelines of human subjects research. To truly rebuild trust and build effective partnerships, we must earn the trust of the community by being worthy of their trust. But what constitutes a trustworthy researcher? A trustworthy researcher is accessible or easily reached and approachable. They encourage open communication. They are attentive, listen, and proactively respond to participant concerns. They are honest and transparent about their goals and motivations. They value safety and fidelity. They are respectful and humble. They develop cultural humility, and they are culturally competent. They understand that there are several factors that may influence an individual's level of trust and are empathetic to these sensitivities. Ultimately, researchers must find ways to simultaneously strengthen trustworthiness and empower participants to promote co-learning.
Okay. Well, so I know that part of the sound was not on, but I think we were able to hear the part of it that to me is the most really at the heart of it, which is that it's on us as researchers to be trustworthy. And so as Erin brought up, you know, we have some historical and other issues of discrimination that we didn't necessarily have a role in creating, but they're part of our baggage as scientists when we go in and work with the community. The Haitian American community during the beginning of the AIDS epidemic, where they were one of the 4 high-risk groups, so they could not donate blood. So and that has had a legacy, that memory of that event has had a legacy that now you go work with the community and you're part of the scientific community that made that happen. You know, there's other history of other events that erode the public's trust, you know, that are well known, the Tuskegee experiments, the STD experiments in Guatemala. You know, and there are other reasons why the public's trust in science has become eroded. And people have these issues of trust in particular when they're feeling vulnerable, right? So we have communities that are vulnerable. Right now, in the age of COVID, we're all vulnerable, right? And we can see what's happened when trust in science is eroded. The NIH right now is investing billions in scientific investment in, for example, in a vaccine for COVID, that if people don't trust it, is going to have a limited impact, right? And so they're very concerned as an institute about the public's trust and about the participation of diverse communities in all of their efforts, and in particular in the vaccine trials around COVID, in the uptake of vaccines. So bringing it back down sort of to our level, right, of as everyday scientists in the community, what can we do to become more trustworthy? And I think that Erin did a great job of really touching on a lot of these matters and thinking about CBPR as an approach that can foster trust. And if we can move on to the next slide, which is one of those, sorry, it's one of those animated ones where you have to press a few times. So I know Erin went over all of this, but I just wanted to just retouch, what is CBPR? And I like this, this is an old diagram, but it's from the AHRQ, that really shows the juxtaposition of CBPR to traditional research. So on the top, you have sort of what CBPR would do, and on the bottom, you have what we think about more traditionally. And that is, is illustrating the full participation at every stage of the game of the community and the community members in the design of the study, in defining what the problem is, what they're most interested in if there's an intervention, in guiding the development of that intervention. It's not just from the literature, designing what the things are that are going to be measured, which aren't necessarily the things that we automatically think about that need to be measured. And then ultimately to really share in the process of dissemination. That means including community members in our traditional dissemination products that we think about. We know publications, going out to conferences and giving presentations, and also feeding back the information that is important right back to the community, right? And so some of these principles of CBPR, are really, really important. You're building on strengths in the community. You're facilitating a collaborative, equitable partnership at every phase of the game. And as Erin said, you're fostering co-learning, you're learning from each other, and you're doing capacity building on both sides, right? So I always like to go back to the Belmont Principles. When my kids were young, I used to take them to karate lessons. I would sit in the waiting room with the other parents and watch them learning karate and listen to the sensei. And one of the sensei's sayings was, "A master becomes a master by constantly going back to the basics." And to me, the Belmont Principles are the basics. And I think that they're really very, very useful. And we all know all of these principles. We've had to learn them. We need to know them to pass our city certification. We know about respect for persons, beneficence, justice. The issue I see, though, is, and I think that Erin alluded to it when she talked about IRBs, which is that as an IRB, we are thinking about and we are keeping the research community in check around these principles when it comes to protection of individual human subjects. But we're not really addressing them. The IRB is not set up to address them. The federal guidelines are not set up to address these principles as they apply to a larger community, not as just the individuals in the community. So when we think about respect for persons, which in an individual human subjects protection perspective has to do with consent, making sure everybody is well informed about what they're signing up for, that they're autonomous agents who are able to sign up without coercion. Well, thinking about applying that to the community, so are the community members or the agencies that you're working with in the community, are they really truly informed about what they're signing up for when they get into a collaboration with you? Do they really understand what's going to be asked of them? Do they really understand what kind of time and effort, et cetera, that's going to take? do we offer potentially inducements that are undue influence, right? We have to think about all these things when we write up a protocol for the IRB about individuals, but we never are really forced to think about them for communities. Beneficence, which is about risk and protection from risk and benefits. Well, you know, Erin gave us a great example of what happens, what can happen to a community, what is a risk and an untoward outcome that can happen to a community because of research, right? It was unintended that this report to the CDC of these cases of HIV among people from the Haitian American community in Miami, it was unintended that that was going to have an effect. But here it did. And it didn't just have an effect on the individuals who were part of that study, it had a very lasting, profound effect on the community. There are other negative findings that we may find in the process of doing a study that could have a negative impact. And it can have a negative impact at many, many levels. So you're working with trusted people in the community, and they're staking the trust that their community members have on them, on you as a researcher, right? So if we as researchers, if we make a misstep, which, you know, everybody makes, things happen, right? Those individuals in the community also risk the possibility of losing the trust of their communities. Those agencies that you're working with have the potential of losing the trust of their clients. What if the process that you're working on causes conflict in the community? What if it causes splintering in the community? Those are all risks that are important to think about. And again, the IRB doesn't force us to think about those things, right? What are the benefits? There need to be benefits that are fed back. They, like Erin said, they're making an investment in this process. And, you know, what are the benefits they're reaping? What are the improvements for the community? What is the capacity building that you're bringing to the table when you work with the community? What is the capacity building at the level of individuals, at the level of agencies? And as Erin mentioned, that I think is so important, how do we measure those things? And how do we make sure that we build it into our measurements? Even if we're not doing an implementation science study, we still have to find a way of measuring the kinds of things that are really important back to the community, that are going to be maybe beyond the things that are in the typical outcomes of a study. And then justice, right? So justice has to do with equal distribution of burdens and benefits, that everybody who could benefit from a study has an opportunity to participate, that the burdens are distributed equally. Well, I think when it comes to the community level, we have to think about this in terms of, you know, I love the idea of the snowball sampling as a way of growing your, you know, initially informal community advisory board, and then eventually an actual formal community advisory board. But when you go in that process, which I think the snowball sampling idea makes perfect sense, and I'm not arguing with it at all. But one thing to think about is, who are the voices in the community that are not getting access to you as a researcher to be able to have their voices heard? Before we started, Deborah asked the question of, what do we do today when there are people in the community who don't have access, for example, to the, you know, Zoom platforms and other kinds of technology that can make their voices heard? And I think that's really important to be thinking about right now. So in terms of justice, you know, also Erin talked about the firefighter who persevered and really asked for her to do the study that she's been doing with the firefighters. And so you working with people in the community who are empowered, right? But obviously you're working with disempowered communities to some extent. That's what why a lot of us are in the business of health disparities research. And so you need to make sure that there's the justice in the ability of those people having their voice heard as well, right? You know, I think some of the ethical challenges in CBPR, which, you know, again, Erin brought to light so well, is that, you know, you're a partner, right? The researcher and the community are partners. But CBPR is typically applied in research with disadvantaged communities. And so the power imbalance, the inequality is sort of built in, right? And to me, one of the toughies is that you have the partnership includes shared ownership of the data, right? And Andres, you can go on to the next slide. Thanks. And there's a responsibility. So as a researcher, you have a responsibility to make sure that, you know, there's shared decision making in how the data is disseminated, that you're transparent from the beginning about how it's going to be analyzed, and you have to realize you have to put that into terms that people, you know, lay public can understand. What is it that we're looking for? What is it that we're looking at? And that when it comes time to disseminating that information, that it gets back out into the public world, the large public world, in a way that the community has a voice in sharing and in making some decisions about, and that it gets fed back into the community and to the policymakers and decision makers that most directly affect that community as well, right? You know, Erin talked about, and we can move on to the next slide, actually. Erin talked about this idea of, oh, sorry, that's okay. Erin talks about this idea about sort of you're in two cultures, right? And, you know, I come from a background where my whole life I've been bicultural, so I'm very used to it, of having to sort of navigate two worlds. And so, but it's a challenge, because you, as a researcher, you are having to have your foot in straddling two worlds, right? You have the lens of science, you have a commitment to your institution, you have a commitment to the NIH or whoever is your funder, that you've said, this is what I'm going to do, and so you need to do it. You have a commitment to scientific integrity, all of those things that are part of your scientist culture, right? But then you also are straddling the role of being part of a community, even if you're not totally a member of that community, right? And so there's a point at which there's sort of a fine line between being a researcher and being an advocate, right? And we have that responsibility to advocate for those communities. And there are times at which those two roles can come into conflict, and we have to figure out how to deal with that, right? So again, I like to think about ethical principles, and so here is another set of ethical principles that I think is more easily applied to some of the work that we need to do in CBPR. And these come from an article by I think his name is David Resnick. And here are some of the ethical principles that I think are really great guides in life, but also in CBPR. So honesty, right? And Erin talked about transparency, being honest about what are the limits of what you are able to promise, and being really, really careful to not go beyond that. Being honest about the funds, about the budget, making sure that, you know, that you really are able to share, let the community, your community partners know, this is the funds that I have available, and here is the piece that we can apply directly to the community for you all to be involved directly in the day-to-day management of this project, the day-to-day data collection, whatever it is. But the need to be honest and transparent is hugely important, and it's hard. It's really hard. I can tell you, I was just working on a proposal that we submitted. Sounded like an enormous amount of money, right? It's an NIH grant, 3.5 million in direct costs over 2 years, which sounds like, whew, it is, it's a lot of money. But then you start looking at everything that needs to cover. And all of a sudden you realize that to get this done, you're going to have to spend a lot of money in the institution, and that little by little, the money that you're sharing with the community is getting reduced, right? And being honest about that. And often we're working in grant proposals where we're having to do this in a very compressed time frame. Or, as somebody mentioned earlier in one of the questions, it could be a really small amount of funding, right? And how do you share that? And I think Erin talked about it being a marriage, right? And so, what do you bring as one person to the marriage, and what do they bring, and what are your assets? And being open and honest about that, I think is tough, and is something that we have to be really honest about, but also be careful not to set up expectations that are going to be lead to disappointment in the future. Objectivity, again, about the financial interest. What financial interest do you have, or does your institution have in this? In keeping your promises, which again, I always try to be as modest as possible in what I'm promising, so that in the end of the day, I'm not going to disappoint people. Being careful about the work at every level, and this is a challenge when you're working. It's hard enough to run a study when you are running everything from inside your lab, inside the institution. It gets that much harder to have data quality and to really make sure everybody's following all the rules and regulations when these things are being done remotely and out of your site. And where you're working with people who are under all kinds of other pressures in terms of their time commitments and in terms of their resources. Openness, respect for intellectual property, really acknowledging the contribution that the community is making through authorship, through including them when you go and present. These days we're not traveling too much anymore, but we're still presenting, and including people from your community partner group as part of those presentations, even if it's to scientific audiences. Confidentiality is, I think, one of the issues that people as individuals and communities as groups, the fear of disclosure, of privacy, of personal information. How is my data going to be used? Especially whether you're doing data collection that's survey data collection, but especially if you're doing data collection that includes biomarkers. People have tremendous trepidation about how their data is being used. And the onus is on us. And of course, we all have the best intentions, but sometimes data ends up getting out of our hands, right? It gets shared, and we have the obligation in many types of grants to share our data. And we have to make sure that the data is shared in such a way that it's not contributing in the end to further stigma, further discrimination, further negative consequences for individuals and communities, right? And again, responsible publication. I think we've touched on this enough times. The article that Consuelo Wilkins wrote, that the videotape is based upon, I think has a really nice figure that I'm sharing here that shows sort of what some of the dimensions are in terms of trust and in terms of building trust. And there's a lot of overlap with the other things we've talked about, but I think that it's important to, see things repeatedly to really have them sink in, right? So being honest, having the quality of your communication. So, here we are dealing with, whatever health problem we're working on, be it cancer, be it COVID-19, be it HIV, be it mental health issues, whatever it is. And we're relying on people, trusted people in the community, to be communicators on our behalf, right? Because really the public in a community is really going to listen to the people in their community who are best suited for relaying these messages. And that's not us as scientists usually. We don't have the capacity to really understand all the nuance of what the meaning is for this community of what we're talking about in terms of this health issue. We don't usually, I can speak for myself, I don't have the greatest means in the world of communicating things in language that's understandable to people. But if we're going to be relying on trusted communicators in the communities to be relaying our messages, then it's on us to help them be trustworthy, right? Make sure that we're giving them information that is as accurate as possible, that is as up to date as possible, that we are equipping them to maintain the trust of the community by being able to be good communicators. And that people can maintain their confidence not only in us, but in the messengers in this community that now we have asked to go out there, recruit for us, to disseminate for us, whatever it is that we're asking people to do in the community on our behalf. So I think that the things in this first box are really are great ways of thinking about dimensions of and content areas of trust. What are the characteristics of trustworthy researchers? Well, as it said in the video that we watched, we're easily reached. We can't always be in our offices, although these days we're kind of forced to, but we need to be accessible on the phone, by text, by email, whatever it is. And so there's a big commitment from us when we decide to work with a community. And so it's not unusual. You don't just go to the events that you plan. You also go to events in the community. And sometimes those are outside of the typical realm of what we do as scientists. I've been to funerals. Sometimes you go to graduations. You go to events that are important to people in the community because there's a shared interest, not just in your research topic, but in the life of community members. I remember as a graduate student in a clinical psychology program being taught that you never disclosed about yourself as a therapist. Heaven forbid, if people asked you if you were married, then you would reflect that as I'm not sure why, let's think about why that's important to you, which, obviously, within 6 months of finishing graduate school, I knew that was out the window. And it's just very similar here. I mean, we have to remain objective as researchers, but we also have to be accessible and approachable and attentive, not just to our priorities, but to the priorities and to the everyday lived experience of community members. And really listen to what they're going through. There is immense suffering in many of the communities that we're working with, which we've all become really, I think, sensitized to today in the age of COVID, that the communities, it's easier for us to be empathic because we're all going through it too. But the suffering and the hardship that is encountered in these communities, we have to be really open to hearing it and to understanding that it makes it challenging for community members to be partners always in the way that maybe we have expectations that people will be partners, right? Cultural humility, really knowing what we don't know. Again, as a lifelong bicultural, actually tricultural person, I'm used to that. But as scientists, sometimes it's easy for us to forget and to be all about science splainers. Not letting people get a word in edgewise, and thinking that we're going in there knowing things that we really don't know, and respecting that people know things that we don't know. So some of the strategies that Consuelo offers in her article, which I think are really important, is balancing the power dynamics. So making sure that even it's things as simple as who talks first, who making sure that if you do have a community advisory board, that the chair of that advisory board is a community member, and that they have a seat at the table. If you have a larger organization, that they have a seat at the table when you're reviewing grants. I know that CHARMS, a Community Advisory Board, has a seat at the table for the grant reviews. And that's about power, right? And that's about sharing your power as a researcher. Sometimes it's about making them key personnel. People from your community might be key personnel in your grant proposal, which means that you have, which is a powerful position because you're restricted in how much you can reduce somebody who's key personnel on a grant proposal. Transparency, again, which I think you can't stress enough. The cultural humility, equally distributing the resources, or at least equitably distributing resources, making sure that people in your community, I often work more with people who are working in agencies as opposed to individuals in a community, but that these community agencies that you're hiring, you're paying for some of the effort of their personnel to help you with recruitment, to help you with data collection, whatever it is. And then, by the way, that you're helping them to get all the FWA, as Erin mentioned, the city certification, not that you're doing the city for them, but that you're making it accessible for them, to make it easy for them to be able to do it in a way that they understand. So again, I think these are great suggestions from that article. Let me see how we're doing for time. Let me move on to the next thing. I wanted to talk a little bit about the use of community advisory boards in research, which Erin started to talk about. And, you know, I think community advisory boards are just an absolute great venue for community members to be able to bring their voice to your research. Now, that doesn't mean that you have to start out with a full-blown CAB when you're just getting started out, right? First of all, there are community advisory boards of different centers, of different, more established researchers. The CTSI has community advisory boards. CHARM has a community advisory board. Claro, which I'll talk about in a minute, has a community advisory board. And so you can access, usually you can access members of the community, through these advisory boards. So you don't have to have your own board. But then you also just start forming them, organically by starting to talk to different people in the community, and little by little you start having, and it's just like having mentors, right? We all have mentors, and we have official mentors, right? And then we have the people who we know that we can go to as sounding boards when we have different kinds of problems. And I think that community boards are exactly, that, except that unlike with our mentors, we have a debt that we have to pay in return to them, which is not always the case with our academic mentors. So I'll talk a little bit about a process that we went through in Claro. So Claro is the Center for Latino Health Research Opportunities. And Andres, you can go to the next slide. It's an NIH-funded center of excellence, funded through the National Institute of Minority Health and Health Disparities. And about 3 or 4 years ago now, we partnered at UM. We had a center, a P60 center through NIMHD, which was called El Centro, and FIU had a center that was called Cruzada, and we decided to unify to go for this grant opportunity, the Center of Excellence through U54. And what we did was, before starting to write, we called a meeting, and this is where I say Mario de la Rosa has been a great mentor to me about how this is done. We called a meeting where we had individuals from, a little over a dozen local agencies, that some of whom Cruzada had worked with, some of whom El Centro had worked with, some of whom we had both worked with. And we brought them together to get their input on, what should we focus on for this grant proposal. And they were very instrumental. And you can move on to the next couple of slides, Andres. This is just some photos. The first slide is a photo of the event itself, which we held at the Alumni Center. And oh my gosh, we have people sitting less than 6 feet away from each other at the same table. How could that be? And we had them talk about these topics, these different topics. And then we did one of these clicker things. I forget the name of the software that does it. And we asked them 3 questions. So Andres, if you could go on to the next slide. We first asked them, you know, and these were all Latino agencies. Both of our centers, originating centers, were really more focused on Latinos groups. And we asked them, okay, so which groups in Miami do you feel are, you know, most affected, most at risk related to substance abuse, HIV, trauma-related mental health conditions? And so we got, you know, them to give us their views, and it shows up in a word cloud. And as you can see from this word cloud, their number one, the group that they thought was most affected were immigrants, but you see some of the other groups that are represented here: youth, several different sexual gender minority groups that you see. The next slide shows you the next question we asked them. And by the way, I mean, they didn't just do this clicking thing. We had them talk together about this over the course of, you know, a couple of hours. What do you see as major challenges or barriers to prevention of these health conditions, which are our focus areas? And as you see, number 1 on their list was stigma. And then you see some other issues that are very prominent: education, culture, lack of access to services. And then we asked them a third question, which is on the next slide, and you'll see the major challenges and barriers to treatment. So the previous one was barriers to prevention. This is barriers to treatment. And again, stigma is very much prominent on the list. And so when we wrote the Claro proposal, we used this. We used the views of the community, and it was important on many levels. It was important because from the most substantive perspective, we knew that if we were going to be doing community engaged research, which is what the Claro proposal was all about, that we needed to be working on issues that were of importance to the community, right? Who were the groups that were important, what they saw as the issues that were important in terms of being barriers to prevention, being barriers to treatment. And then we also wanted to focus on the strengths. And you see that in your next slide, which is what are the resources that the communities have that can be harnessed so that we can address these issues. And as you see, and as a family researcher, it was really nice and gratifying and very convenient that family came up as number 1. And so we based the interventions in the 2 proposals that we ended up putting as part of the center grant were both family intervention studies that address the barriers that were mentioned earlier, that were with the communities that were mentioned. One of them is with immigrant farm worker communities, and the other one is with sexual gender minority youth who are at high risk for self-harm. So we knew that by putting this into our proposal, first of all, you know, from a grantsmanship perspective, to be able to, you know, to know that you have the backing of the community, to be able to say in the proposal that your ideas were formulated in collaboration and with guidance of the community is very helpful. But then when it came to the day of actually doing these studies, we were able to go back to these communities, and the buy-in was so much more, was simplified because they had actually contributed to these ideas. And I mentioned a little while ago that we were working on a proposal that was just submitted. And so all these years that we did get the Claro grant, and we're, in year 3 of that cycle. And we put in this response to RADx UP initiative, which is for working with underserved populations to increase access to testing. And so we've had a community scientific advisory board all these years, made up of many of the people who were at that initial meeting, and they've been very active. They have a chair and a co-chair. They meet quarterly. They have been integrally involved and employed in doing the needs assessments that we've been doing as part of our work. And when it came time to putting in this RADx proposal, we went back to our CAB, and we call it the CSAB because scientists are part of the group. They're a minority, but they're there so that there's an interchange as part of these CAB meetings. And we went back to them and we said, what are your ideas? Here's this opportunity from the NIH, and these are the kinds of things that they're interested in having us do. What do you all think? Who are the people that we should be working with? Who are the communities that are most at risk? What are the barriers that you see that are raising the risks to COVID in these communities, that are making people not necessarily getting the testing that they need to be getting? And so the CSAB, was right on board. And it's really, the point is that you're making an investment at the very beginning. And this is a long-term commitment. Erin talked about working with the firefighters. This is something that is recent in her history, but it started 6 or 7 years ago, right? You're making long-term commitments. And by making these long-term commitments with our community advisory board, we were able to really involve them and propose something that not only is a strong for a proposal, but hopefully, if and when we're funded, makes it that much more feasible, possible, meaningful to these communities, that we go back there to work with them so that we can actually do the work that we proposed. So I think community advisory boards, and in the meantime, until you really are ready to have a board, the community advisory individuals that you have that are your advisors and that are your partners are really just absolutely essential for keeping you in check as a researcher, in check in a way that the IRB does not, because we're not prepared to do that as an IRB. We think as an IRB about the human subjects protection of individuals. But having these advisors is a way of keeping us in check and keep helping us to maintain our ethical compass and our in terms of doing the right thing. And I think that's it in terms of the slides I had. So I think I'm going to close there and open things up for discussion and question, and and for both myself and Erin, and for anybody else who's, and Deborah, and anybody else who's part of the meeting.
Thank you very much, Vicki. That was really, really interesting. And I actually learned a lot about your work that I was not familiar with, and your process. It was interesting hearing the process from both you and Erin to kind of see the similarities and actually also some things that were different. One of the comments that we made was related to the fact that these sorts of discussions that we're having right now are also similar to some of the issues that we face in global health research. We have a lot of people at who do research in other countries, and we're faced with very, very similar issues in terms of community buy-in and but very long distance, and it's especially challenging now. Do you have, either of you have any comments about global research and how it might be similar or different? I'm not sure about your familiarity with that.
Well, I mean, actually, Deborah, I think among us here, you're the person who's probably done the most by far of research in other countries. And absolutely, I mean, if you're working, here in the United States and you're doing research with communities in other countries, it's that much more challenging, and the ethical issues, I think, are magnified, right? Because you need to know what is the truth on the ground. Erin drove through looking. I really admire that she did this study, and she looked at the data, and then she said, let me get in my car and go see what are these streets, what are these neighborhoods where the cancer rates are elevated. And she's like, whoa, I'm in Little Haiti. The signs are written in another language. And so I think that that's just such a great lesson in we need to know the on the ground reality of who we're working with and the lived reality of who we're working with. And again, Deborah, I think that you're, obviously you've lived this. And so, yeah, I think it is absolutely very parallel.
Dr. Kobetz, do you want to add anything?
Sorry, guys, that I'm wearing a mask. I have some workers in my house. So trying to practice good public health guidance. I don't really have anything else to add. I think that Vicki did a really beautiful job sort of summarizing the answer to that particular question.
Okay. I would add that that from my own experience, and here's the QR code, just to remind you, you just hold put your phone on camera and hold it up and show your phone the image, and it will go straight to the survey. I just want to add that working in other countries, I think is especially challenging because people of European background have a really bad reputation for what Dr. Kobetz described as parachute research. So parachuting in and collecting information and then leaving again. And also there's a lot of distrust. And I think that the experiences are very similar to those that were discussed during the talks. I wanted to ask, we talked about, you mentioned a little bit about inclusiveness. And, one of in the 3 pillars of research in terms of beneficence and justice is the idea that everyone is included. So is that inclusiveness. What would you recommend as strategies to be inclusive in terms of conducting research when it's so difficult to reach some people now? I'm asking.
So, Vicki, do you want to answer that or you want me to start?
Why don't you go ahead?
So this is something that we are honestly struggling with quite a bit because the inability to be physically present in communities, I think very much affects our success in reminding people that we are partners and allowing us to do recruitment that has often been identified by our community stakeholders as the most appropriate for garnering interest in a given study. So, I mean, normally like my community health workers hang out at bus stops and on street corners. And now if someone were to come up to you, I mean, you'd be like looking to see if they had a mask and you'd probably be walking in the other direction as quickly as possible because we really want to limit our engagement with people whose like COVID exposure we can't appreciate. So, we've been trying to be creative, working through the social media channels of some of our community partners. We were actually really involved early on in a county-wide response to COVID, which put us back into the communities. And so we had a visible presence. Zoom helps a little bit. So Sylvester's Office of Outreach and Engagement, which is all grounded in the tenets of CBPR, has been working with community leaders to put together like a Zoom conference or Zoom learn-ins to discuss topics of interest, some of which are COVID specific and some of which are more aligned with our normal cancer center focus of conversation. It's not easy. And I keep sort of challenging my team to think really creatively about how we can maximize opportunity given the need to physically distance. And I wish I had like an easy solution, but I don't, because it's something that we're certainly struggling with. And in many of the communities we serve, we take for granted some of these platforms that like we readily use as part of our new normal, and our interactions with colleagues, but they're not readily accessible. And I'm not sure how we actually support that. So I don't know, maybe Vicki has some other ideas, but it remains a point of sort of tension for us.
Yeah, in Claro, we have, several studies. We have 2 large randomized studies as well as, at this point, about 7 or 8 pilot studies. And one of our larger studies, which was with the farm worker community, is a father and son intervention, and it's headed up by Patria Rojas at FIU. She was struggling with recruitment before COVID. I mean, it was just really hard to get men, who are working in the fields and who are just exhausted to come into a local agency to do these group intervention sessions. So she was really struggling. Then COVID happened and we had to switch over to remote modalities. And the best thing that ever happened to her recruitment for this study was having to go remote. Because then you had a situation where you had these men who were exhausted, but now they're having an opportunity to be part of this intervention via telecommunication. And what she did to make it accessible was, and I'm sorry, I don't know the technical specifications of it, but she put her intervention onto a video format that could be watched on flip phones. So it was low tech enough that included, it didn't have to be people who had access to, computers, laptops, or even smartphones. It could be watched or listened to on flip phones. And she describes having participants be part of the intervention or part of the, of the data collection, and she hears all kinds of ambient noise because, he'll say to her, well, yeah, I'm on my patio because it's the only place I have any privacy right now. And so people who in the community, what is really impressive is they're wanting to be part of these endeavors, of really having the desire to help themselves, to help their families, to help their communities, and to be part of these things. And they're used to, more often than we are, of just dealing with adversity and having to work around stuff. And by and large, and it remains to be seen, for example, if this intervention is as effective in this modality as it would have been in face-to-face modality, but she has been able to get around it. And for the first thing she did was to reach out to all of her participants by phone and say, we're going to be moving to this modality, and what do you have access to? What do you have? Do you have internet? Do you have a flip phone? Do you have a smartphone? Do you have a tablet? What is it that you have? And so first of all, just finding out sort of a needs assessment of what they had access to. But it's challenging, but in this case, at least, it was, I'm not ready to say yet it's a success story because we have to see how it turns out, but it seems to be workable.
That's really interesting, and I think it's a really helpful answer. Dr. Kobetz, you answered that question a little bit, I think, also. And so there's kind of a flip phone, a flip answer, the reverse. So that sounds like that's something that worked out. And I know that for our own studies, let me chime in, that we have been doing, as a lot of people, we've been doing remotely all of our study activities, and we're getting a good response. Not everyone wants to talk on the phone for a half an hour or an hour, or in some studies 2 hours, but with a little bit of planning, it does seem like it's possible to do. Well, we are coming to the end of our 2-hour block. It's hard for me to imagine, and I'm out of questions. We've got the QR code up one more time. Just take a moment and hold your phone in front of it. I'm going to try and do that myself just to make sure I know what I'm talking about. Yep, I do. And it says QR code detected, open RedCap Miami EDU link. And so it'll send you right there. I want to thank everybody for participating with us. And I want to especially thank Dr. Kobetz and Dr. Behar-Zusman. Thank you very, very much. Thank you, Andres Vasquez, for putting this all together. And thank you, one more person, Oriana Zerrillo, for taking the time to supervise this group. Thank you very much, everyone, and have a great day.
Thanks so much for the opportunity. Bye-bye.